Okay. Thank you. So, again, as I said, the starting point for this presentation is this really list of malfunctioning and errors, and try to give you practical examples of how we could avoid radiation accidents by optimizing some of these points. Now, I will be skipping the DRLs topic because Shadia is going to have a dedicated lecture about it right after me. But I will try to go through the 6 different points and give you practical measures for that. So before talking about optimizing acquisition protocols, you really need to know how the system works. The system is obviously made of an X-ray tube and a detector, but there's actually a third component, which is called the automatic exposure control system. And this system plays a huge or a major role in the dose and in the image quality. So you always need to start your procedure with fluoroscopy. Do you know why? Why you can't start with an acquisition? Okay, you need to start always with a fluoroscopy because the X-ray tube will start from a, let's say, starting point. He needs to start somewhere. So he starts with the lowest KVP, lowest MAS, and then he sends the signal to the detector. The detector reads out the signal and sends this information to the automatic exposure control system. The automatic exposure control system will evaluate the system. He will calculate a patient equivalent thickness and then says, okay, you have a predefined acquisition protocol, so you have a predefined image quality at the detector level. What should be my acquisition parameters to meet this target image quality? So the automatic exposure control system calculates the patient equivalent thickness, looks at your acquisition protocol, says, I have an image quality to meet, and so I boost up my KVP, my MAS, or whatsoever to reach this acquisition quality or target image quality. And afterwards, you can be sure that whichever or all subsequent acquisitions in fluoro mode and in acquisition mode will meet this target image quality. Now you have to pay attention that if you change the beam angulations and you use the previous parameters, so you don't do a copy again, you will have a different image quality and a different dose. If you want to optimize it, you should start again with a small fluoroscopy so that the system, yes?
But you always do fluoroscopy before sitting, is that what you're...
Yes.
So you always have to do fluoroscopy
yes.
before you decide to sit it?
Yes.
So it happens all the time, right? There is no exception to that?
Obviously, there's no exception to that. Sometimes I saw it personally that they're on a hurry or something. They change the beam angulation and they start with the acquisition. It's rare, it's true. So, if you want to summarize what an acquisition protocol means, you have to know that an acquisition protocol is a predefined target image quality at the detector level. It's also a system called AEC, which automatically adjusts the image quality or the acquisition parameter to reach the image quality, the target image quality. Here I want to insist on one thing. If you are not using optimally the system, let's say you're putting the detector far away from the patient, the automatic exposure control will send much more radiation to meet the target image quality. So you could end up doing 2-3 times more dose just because you've put the detector far from the patient. So the problem also with these optimization protocols or with these protocols is that you can change them during the procedure. You don't have your hands on them. You have to predefine them or preset these optimized acquisition protocols. And for that, you need the support of a medical physicist or an application specialist. Now, where can you find this information about protocols? Which protocol you are using, do you know? For GE users, it's more or less easy. They're really on the screen, and you know where to find them. For Siemens and Philips, they're a little bit hidden. You would have to really click 4 or 5 different places to find them. Now, so I'll stick to GE. For the time being, GE offers 4 different dose strategies or trajectories. IQ+, IQ standard, RDL+, and RDL standard, with a very different dose level. So in my hospital, at least, IQ+ and IQ standard are only used for obese patients. It happens that last time I came with Shadia to one of the hospitals, the default was IQ+. So it means that we have to pay attention to this. In my hospital, RDL plus is the default for adult patients and RDL standard for pediatric patients. For fluoro, there are also 2 dose reduction strategies, at least for GE, balanced IQ and max dose reduction with 50 to 60% less dose. Now, obviously, there is a balance to find between the good image quality and the dose. I'm not saying we have to have lowest doses. We need a very good image quality, that's for sure. Now, let's say you have optimized your acquisition protocol, but you still have a bad image quality. Now, there are some accessible parameters, right? You have access to a fluoro or DSA, you have access to the magnification, pulse rate, and the detail level for GE. So first, do you know how much difference is there in terms of dose between fluoro and DSA? Okay, this is just a summary. In short, in 1 minute of fluoro, you would be more or less delivering 18 milligrays of dose. Whereas in 1 image of DSA or acquisition, you would be delivering almost 2 milligrays. So if you are at a 7.5 image per second or 15 image per second, in just few seconds, you would be able to deliver a dose equal to 1 full minute of fluoroscopy. So that's a major difference. Now, what about magnification? Now, this is a standard GE magnification, at least on IGS equipment. And roughly speaking, this is the order of magnitude of the dose evolution. So you increase the dose by 30 to 50% with each step of magnification. What about the pulse rate? So you have between the range of pulse rate of possible pulse rates from 30 to 3.5 image per second. And the dose actually decreases not really linearly, depending on the patient thickness, but it roughly decreases between 25 to 50% with each decrease of pulse rate. So your default pulse rate should be 7.5 image per second. And I'll talk about it in the next slide, but you can also synchronize this or adapt the pulse rate to your patient, to the beeps per minute of the patient heart. Yes?
Sorry, many labs, actually this is a very important slide, and I'm sorry to interrupt.
No, it's okay.
Many labs work at 30 frames per second,
yes.
And they don't even know it.
Yes, that's true.
They don't even know it, which means they don't look back and say, what am I at right now? 30 is not necessary this day and age.
We only use it in 3D.
7.5 is better. But it's worth it to go back at the lab and say, what am I working at? It's not something the technology is going to ask
Absolutely.
you when you start.
Absolutely.
It's by default, and that default could be there for years and nobody's asking.
Absolutely. Absolutely. Okay. And the last parameter, it's really specific for GE. It's this low versus normal detail level. And they often tell you, or at least when the application specialist or GE comes and trains you operators on the system, he says, okay, if you don't see good, or if you don't see well enough, the first parameter to change is the detail level. But when it comes to the dose, actually the detail level increases the dose by a factor 2 and up to 2.5. If you compare it to the magnification, maybe it's worth first changing the magnification, and then if it's really not enough or not yet good enough, then go back and change the detail level, for instance. It's also important to know that all these changes are only changing the quantity of radiation sent from the tube to the detector. So you're only playing on the mass, not on the KVP. If you need better contrast, no matter what you change, you won't really, at least on these parameters, you won't really gain in contrast. You would have to change the acquisition protocol to gain in contrast. Now I want to put one caution. These are equipment-specific data. These apply to mine because I've made some measurements and also looked at the user's manual or whatsoever. But you should have this information for your own system. You should look at it or get support from the application specialists. I know you don't have medical physicists here, but it really plays a major role. Now, the third, let's say, parameter we have identified as a failure was that the system was not really efficiently used. I've seen this sometimes, even in my hospital. They sometimes forget to use edge filters. And filters not only provide better image quality, but they could also decrease the dose by up to 60%. The second parameter is collimation, and collimation here really improves the contrast, lowers the dose, and most importantly, limits the beam overlapping. So the risk of having skin injuries mostly come from this beam overlapping also. So collimate as much as possible gives you this opportunity to save on the dose to the patient. Now, table and detector position. Can you tell me which of these four is the best, at least radiation protection wise, but actually even image quality wise? What's the best setting? Why did you say C? A, actually. A. Why? You put the tube as far as possible from the skin. The dose decreases with an inverse square law. So you get much lower doses. And the detector is closest to the patient. So you lose less radiation. So you improve your image quality. And in terms of dose, actually you give 5 times more doses in setting D. 2.6 times more doses in setting C, and that's just the direct dose. I'm not counting the scattered radiation. So it's very important to have this in mind. Put your detector as close as possible to the patient, and your tube as far as possible. Now there's one important parameter, additional parameter. It's this distance. Why is this so important? Because you have the anti-scattering grid, which could actually, instead of improving the image quality, increase the dose if you don't respect the focal distance of the grid. Now on US equipment it's 110 centimeters, in Europe it's 100 centimeters. And the dose increase, if you don't respect this focal distance, is up to 30% and somehow or sometimes even more. If I may give a specific recommendation, I would say definitely remove the grid if you can't put the detector as close as possible from the patient. It's far better for the radiation protection and also for the image quality. And for pediatrics, definitely remove the grid. Now, the next parameter is the synchronizing the acquisition. Synchronize it to the heartbeat, but also to the contrast fill. Sometimes I remember some of the acquisitions were done even before the contrast product was injected into the patient and they started the acquisition. So just try also to anticipate on this to remove the dose or to reduce the dose. Sorry. And one last parameter, which is also very important, is the patient setting. Put the patient hands outside the radiation field. It reduces the patient equivalent thickness as seen by the detector, so it really reduces the dose by 20 and even up to 50% sometimes. Depends on the angulation. And also avoid extreme angulation, that also decreases the dose. Now these were the most important parts. I have only 1 minute left, so I'll go through the last points quickly. A QA program is very important. The main message that I want to have or to show you is that maintenance is not quality control. Quality control, it involves the entire imaging chain, the tube, the detector, but also the software that you are using to reconstruct. So it's important to have this quality control on the entire imaging chain and independent from the manufacturer. Okay? And in France, as I told you, we have massive reinforcements of the regulations for QA, specifically for interventional procedures and in vascular labs. Knowledge of radiation risk, I don't want to go back, that's the present presentation. Main messages here, skin severity increases with dose. If you don't see an effect, it doesn't mean that there's nothing happening. If you repeat the procedure, you need to know that the skin might react differently from a normal skin or non-irradiated skin. And then skin changes can occur months after exposure. Now that's the last point I want to show is the alert levels. Now this is my local procedure, okay? So we have an action plan, an exposure level, and a person involved in different tasks depending on the exposure level. So For a skin injury follow-up threshold, that's the EuroCTO recommendation, and that's also the national recommendation in France. So when the dose exceeds this limit, different professionals have to perform different actions. I don't want to go through this, but mainly cardiologists have to inform the patient of the risks, and in agreement with the medical physicist who has to calculate the dose, we need to set up a timeline for the patient follow-up. And only last week I had a patient with the third intervention and 11 grays to the skin, so it really happens. So we agreed with the cardiologist to set up the follow-up for 3 months. So we're sending letter, the secretary is sending official letter to the patient informing him that he needs to come back to us for a skin evaluation 3 times in the upcoming 3 months. So at the end, the take-home message is that even a straightforward procedure can become a high-dose one with poor technique. Optimize your acquisition protocols. That's really a key parameter to reduce the doses. Limit the use of acquisition and keep beam on time minimum with 7.5 frames per second. Don't overuse magnification, and also use the low detail level on GE equipment as default. Consider change the beam orientation. The recommendation that we give is at least 10 degrees, minimum 10 degrees of change, so that you don't have a very huge overlap. And then put the table as far as possible from the tube and the detector close to the patient. Work without at the focal distance or without the anti-scattering grid if you are in pediatrics, or you can really not put the detector close. And last but not least, don't forget, low patient doses also means reduced staff dose. And we have actually just finished this also European project, and we've proven that the dose to the eyes of the operators increases the risk of cataract by a factor 2.3 with a cumulative dose to the eye of at least 1 gray. So maybe next time I can tell you about the operator radiation protection. Thank you for your help, for your attention.